Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts and learn how to craft your ideal birth. We will tackle the scary and weird questions that come up along the way and provide answers that are driven by science and evidence-based recommendations. I'm going to show you how to redefine parenthood and choose what's best aligned for you and your goals. With 10 years of experience in family education and a master's degree in human development and family studies, I'm ready to help you navigate pregnancy and explore your birth options to free yourself of fear surrounding childbirth. My goal is to help you have an informed and confident labor experience, plus an empowered and joyous postpartum. Tina, welcome to the show.
Hi, HeHe, how are you?
Doing well. I'm so excited to have you. Not only are you like someone that I obviously look up to, but we've kind of become friends, and it's even more fun when you get to have your friends on the podcast, because I think it really gives our listeners a chance to kind of, get that human feel when it comes to medicine. A lot of times, medicine can feel very cold and distant and very transactional. And so I think it's really fun when we can bring that human touch back to medicine.
Totally. And it can even feel that way working in it. Like, it's not like because I work in it, it just feels like magically different. Like, it can still feel that way even when you work in it.
Yeah.
But I'm so glad we had a chance to meet in Nashville. That was so fun.
Yeah, that was fun. I had a blast at the Lila opening, and I have been hanging out in my Lila wear, even though I'm not pregnant. It's almost manifesting a pregnancy, question mark.
Right? You're like, come on, come on, come on.
Maybe.
Yes. You're ready. You're like,
Lila was so fun. And it was such a good group of people too. And you never know when you meet people offline, whether they're going to be the same as they kind of portrayed themselves online. And everybody there was such a genuine human.
So good. I was like, oh, I love these people. It felt like Love is Blind. Like when you know people, just their voices they're flat on a screen. And then you can like touch them and you're like, wow, your voice is coming out. It was wild. Anyway, you're lovely.
Human.
I'm so happy
I
to
can
be here.
You. Yeah,
Yes,
absolutely.
agreed.
Well, thanks for joining me.
Yes.
Okay, today we're talking about postpartum hemorrhage. Kind of a scary topic.
It's
kind
heavy.
of a thing that nobody wants to happen to them, obviously. Kind of a thing that no medical professional ever wants to encounter. And a lot of times I think it is something that people learn about after the fact. And so today's episode, I'm hoping that we can kind of educate people on what postpartum hemorrhage is, what increases your risk for experiencing it. What are the things that we can do to maybe mitigate those risks, to hopefully, fingers crossed, if we can avoid it? And then finally, just what do we need to be asking our providers and our prenatals? And then what can you ask your provider if you do experience a hemorrhage? So I'm hoping to kind of tackle this conversation before it happens to us, rather than what I think a lot of people experience is they learn about postpartum hemorrhage after they've already had it.
As someone's hammering down on them and they're expressing a clot the size of a softball. And like, what was that? You're like, oh, that was your jellyfish. And I think that's good in any part of obstetrics, though, because I find a lot of people don't find out about the things that are intense that could happen until they're happening. And I think that really ties into birth trauma and how it affects people. So I really think that conversations like this are important to be having when you're in a relaxed mental state and you can really absorb it and you can ask the questions that you want to ask, because if it's happening then and there, you're not asking those questions. You're just sort of getting through it and then trying to figure out why it happened and could you have done something different. So I think these conversations are really important for not only people in the medical community to have, but also people to have it with their providers before it becomes a problem.
Yeah, what you're talking about kind of led me to create the Birth Lounge, because I found out so many people were saying, I felt like things were being done to me in my labor instead of me being an active participant, or, things kind of spiraled and I didn't know what was happening and I didn't feel like I could speak up because it felt very emergent. And so I just kind of went with the flow. I just did what I was told to do and I didn't really understand. And so when I created the Birth Lounge, I vowed to have these hard conversations that on the outside and on the surface seem very scary. But once you dive into it, postpartum hemorrhage is not scary in discussion. It is scary when it happens to you, but if we can have a discussion about it, if you do experience it, you typically feel much more in control. You kind of know what is going on. If you have questions that you want to ask, a lot of times you're able to ask those because you already kind of absorb the information of, okay, this is a risk of birth. If this happens, here are the things that might want to be on my mind. Where typically, if you don't know that going in, you typically don't have the opportunity to ask until your second or third birth, you know?
Totally. And I really think people need to be able to sort of feel like things are happening with them as opposed to
Totally.
them, right? And that's true, like I said, of anything. I mean, the best time to learn about an epidural and the side effects is not when you're having like 10 out of 10 pain and you're
Totally.
transitioning through labor, like what are you absorbing in that moment? Nothing, right?
Nothing.
So this is why I think birth classes too are so important to take before you have a baby, and you can learn about things like this. But a lot of times we don't go into huge detail. I mean,
Yeah.
no one wants to come into a prenatal class and they're like, okay, we're going to talk about what happens if you start hemorrhaging. And you're looking at your husband like, what? Your partner's like, holy crap, what did you sign us up for? So yeah, I agree. These are amazing conversations to have before the fact.
Okay, cool. So let's kind of start there. Can you tell us what a hemorrhage is? For a lot of people, it just feels like, all right, I bled a lot, but there has to be a
Hmm.
little bit more to that. What is the true definition
Yeah.
of a hemorrhage? And I know that it's different from vaginal birth versus a
Right.
C-section.
Right. Yeah. So it's basically an excessive amount of bleeding. But again, that can be really hard to determine because you have to think about like when there's birth, there's so many other things coming out of you other
Hmm.
than blood, right? Like there's amniotic fluid, there's mucus, sometimes there's stool, there's, all sorts of things. So it can be really hard to figure out how much blood you actually lost. In a vaginal birth, it's more than 500 mils, and in a cesarean section, it's more than 1,000 mils. So yeah, it sort of varies depending on what you're having done to you. Obviously, we would expect you to have more bleeding in a cesarean section when we're cutting things open versus a vaginal birth where we are hopefully not doing that.
Sure. Okay. And how are we evaluating this blood loss? I know that I've heard of things
Hmm.
like estimated blood loss versus a cumulative blood
Right.
loss. How are we
Right.
determining what is
You
too
know,
much bleeding?
I think that this must vary site to site because, like where
Oh,
I work, we're just instituting it's called QBL, so quantitative blood loss. So
sure.
we're doing you can do things like you can weigh the pads, and you know that how much weight can translate into how many mils. Some places have the drapes that will actually catch the bleeding, and but then people can differ on when they start to count the bleeding. Like you would assume with birth that you're going to have bleeding. So does that actually count into a postpartum hemorrhage, or is that an expected blood loss and then afterwards a postpartum hemorrhage happens? So I would imagine that it's probably different place to place, but there's a few things you can do: weighing pads, weighing like under pads or soaker pads and things like that, because those can get saturated. And then if they just get tossed into the laundry, you've basically tossed away a bunch of blood. And I think the big issue a lot of times with there are postpartum hemorrhages where it's like immediate and it's intense and you're like, holy, this person's hemorrhaging, it's really bad. But there's also like kind of slow postpartum hemorrhages where that person is actually losing quite a bit of blood, but over a bit of a longer period of time, like over their stay at the hospital, right? But we're not catching it because it's not happening like all at once, right? And I think this is where we're a little bit behind in the times. So I
Mm.
think that's why a lot of places are coming out with this QBL where you're weighing pads as you change them every single time you change them. Because if you were to actually take those pads and add them up, then you might actually catch a postpartum hemorrhage starting, or you might actually catch that they have bled excessively for their type of birth and be able to be like, oh, wait a minute, maybe we should watch them a bit closer and that sort of thing. So I think everywhere has their own ways. For a long time, we just sort of eyeballed it, which isn't really accurate. Sometimes in C-sections, we eyeball it too. But again, it's tough because you have a canister that's collecting all of the things from the birth in the operating room, but like how much of it is fluid, how much of it is blood? Like, yeah, it can be really tricky to determine.
Yeah, hard
I
to
think you also have
tell.
to take into account, yeah, like how the person is feeling. Because I don't know, in my opinion, like somebody who has a bigger blood volume or maybe a larger body mass, they might have a little bit extra blood to be able to accommodate losing versus somebody like yourself that is a
Yeah.
little bit smaller, you know what I mean? And some people are just really sensitive, right? Some people were maybe anemic before they had their baby and then they lose this amount of blood and then they feel awful, right? So I think really how you're feeling too is going to play into like, is this a true postpartum hemorrhage or not?
Which kind of speaks to speak up if you're feeling bad, right? Even if your medical
Yes.
staff is not saying like, we're worried about your bleeding or
Yeah.
really anything. If you don't
Yeah.
feel right, you should be
Yes.
saying, "Hey, I'm feeling X, Y, and Z. This may
Yes.
totally be normal. I've never had a baby before. This is my first baby,
Mhm.
so it may be normal, but is this what you're expecting, or is this kind of bringing up red flags for you if I tell you that my head is hurting, I'm feeling lightheaded,
Mhm.
I'm having a
Dizzy,
hard time
lightheaded.
breathing, I'm feeling
Yeah.
dizzy."
Yeah. Totally. It's so important because a lot of times too, I always say this, you're gonna know how you feel before my machine knows how you
Oh,
feel.
yeah.
And
That's good.
postpartum, if things are going well, usually we have a blood pressure cuff on you and we're checking you every 15 minutes. We're checking your uterus every 50 minutes, we're checking your vitals. But like that 15 minutes in the case of how you're feeling or if you're bleeding and we don't know you're bleeding, that can be a big difference and we're not going to pick it up till the next time that machine runs off. And if you're just sitting there thinking, "Oh, like I feel like I'm going to throw up or I feel dizzy," but you don't say anything, like your blood pressure could be really low and we wouldn't know. This happened to me when I got my epidural and I said, ooh, I don't feel good." And the nurse looked at the machine and she goes, "Oh, your blood pressure's good." And I said, "Take it again." And she ran it again. And sure enough, it was like
He
72
said,
on
"Oh, it's
48.
not
And I
good."
was like, yeah. So it's like, it is super important. Like, tell your staff how you feel in a C-section, tell your staff how you feel in a vaginal, just tell them all the things.
Yeah, and
Yeah.
never feel like a burden. I know it can feel very
Yeah.
burdensome. They are
It
very
can.
busy, and I get it, and they're moving fast, and they clearly have a to-do list
Yeah.
of tasks to do, but you speaking up about what you're feeling is beneficial for everybody in the room, and I promise you, your medical professionals
Hmm.
want you to say something, even if
Hmm. We
it's
do.
on, like, their busiest day, in their busiest moment, they still
Yeah.
would rather you say something than you not. Okay,
Totally.
so can you tell us a couple of other signs that someone might feel if they're bleeding too much that might be something you want to talk to your medical providers about after you have your baby?
Yeah, I mean, you hit a ton of them. If you're feeling the signs of blood loss, like dizzy, lightheaded, like you want to throw up, the room is spinning, you're having any sort of chest pain, you're having
Yep.
shortness of breath, those are all really good things to mention. Also, if you feel like the amount of flow coming out of you is a lot, and I know that that's hard because if you've never had a baby, you don't know what that feels like or how much should be coming out. But if you're feeling any sort of like flow while you're laying still and you're not doing anything, because we expect when anybody stands up after having a baby or if they've been laying down, you're going to have an initial gush. It's kind of like the first day of your period, everything is pooling, you're going to have that gush. But if you're laying there totally still, not changing your position, and you can feel a flow, that is concerning. If something falls out of you that feels, I always say it feels like a jellyfish, but
Yeah.
that could be that could be a blood clot coming out. So those are the things we want to know about, like, oh, I just had a gush, like, and we'd be like, oh, I'm going to check and see, right? And sometimes gushes can be normal, but a lot of times I would rather know that you felt a gush and you're laying there doing nothing than that you didn't know and that sort of thing. So, yeah.
Cool. Okay, and then when you go home after you've been
Hmm.
discharged, if you're feeling a pad
Yeah.
in an
Yeah.
hour or
Yes.
more,
Yeah.
that's concerning. Also,
Yeah.
blood clots. How big
Hmm.
are we expecting them to be? That's normal versus, oopsie, I
Yeah.
should probably call my provider on this one.
Yeah, I always say clarify this because a lot of different providers have a different sort of area of comfort with blood
Okay.
clots. I mean, I'm Canadian, so I always say like a toonie, but if
Okay.
you're not Canadian, some people will say like a ping pong ball or a golf
Okay.
ball can be normal. But again, I think you have to take that with a grain of salt because if you're filling or almost filling a pad and you've put out like 3 golf balls, well, they're a golf ball size, they're not bigger, but like there's 3 of them. So these are always
Got
things
it.
I say, please don't feel any sort of way about phoning somebody, like phoning your
Totally.
outpatient department, phoning your provider, because yeah, and also, how do you feel? You know what I mean? Have you expressed 1 golf ball size clot, but you feel terrible? You feel dizzy, lightheaded, yucky, you want to throw up. Have you expressed 3 and you feel fine? You know what I mean? So I would say if you're at all concerned, follow up with your provider because they all have these different, yeah, grains of acceptable to them. Usually it's around like a ping pong ball. But
Yeah.
again, that can be alarming to somebody who goes to the bathroom in the middle of the night and feels like they've delivered another baby in the toilet.
Oh,
And
really?
you're like, what is happening? Right. So, yeah, I would say just check in with how you're feeling and check in with your provider.
Yeah, absolutely. Okay,
Mhm.
cool. That's really good to know. One other thing about going home,
Mhm.
sometimes you go home and your bleeding is normal. I've seen this a handful of times. That's why I want to bring it up. and then all of a sudden you get
It
this big
increases.
gush of blood. That
Mm-hmm.
is problematic, you guys. Now, in my experience, it has always been a retained placenta, and those people almost always need to go back to the hospital and their
Mm-hmm.
providers check them out and they have a piece of placenta retained.
Mm-hmm.
What have you seen, and or are there other things that might be going on if you're like bleeding normal and then all of a sudden you get this
Mm-hmm.
big gush of blood and you're like, whoa, that is totally not
Yeah.
normal.
You know what? Some providers will say that that's totally fine.
Wow.
I would always check in. If it
Yeah,
was me
okay.
personally, I'd check in because I always want to err on the side of caution, especially with a hemorrhage, because it can get out of hand really, really quickly, right?
Fast.
So, but yeah, I always say your bleeding shouldn't increase. Like when we are checking you, we are making sure that your bleeding is staying the same or decreasing, right? If your bleeding is increasing from check to check, or it is getting brighter or it's getting thinner in consistency, these are things that we're going to be like, that's not really what we're expecting to happen. Maybe we need to further investigate. So I would always caution people, if you go home and you're down to like a regular maxi pad and all of a sudden you fill up the maxi pad and you're bleeding heavier, that would always be to me like a sign of a do not pass go, like phone somebody, find out. Yeah, I wouldn't mess with it.
Yeah. And look,
Yeah.
guys, worst comes to worst, it's kind of like going in to
Mm-hmm.
check on your baby in the last part of your third trimester is like, worst comes to worst, they say this is totally normal. This is what
Yeah.
we expected. Go back home and
Yeah.
enjoy your time with your baby. You would always
Yeah.
rather check and be safe than sorry. So just call
Always.
and say, I'm not sure if this is normal. This is what I'm experiencing. How does it sound to you? Your medical professionals will know whether they're
Totally.
concerned or whether they're not.
And that's important too, because like your medical professional also knows things about you that like Google does not, right? So I
Totally.
always say like it's great to kind of know what to expect, but there could be something happening with you specifically in your pregnancy that would make them a little more anxious if you told them that, and there would be
Yeah.
some that they would be like, no, it's totally fine, it's totally okay. And I am a dweller by nature, so if it were me, I would not go back to sleep. I would be laying in
Yeah.
bed being like, am I gonna bleed to that? What's gonna happen to me? Like, what's, yeah, is this normal? Should I call them? What should I do? Like, and yeah, so I would not go back to sleep because I'm a dweller. Maybe other people aren't. I always wish I wasn't a dweller, but anyway, I always say we would rather see you and have it be nothing than not see you and have it be something.
Totally,
Yeah.
totally. I think everybody in medicine, even someone like medical adjacent, like doulas, we all agree on that. It's like just
Hmm.
call just to be safe. And if it's nothing, then wonderful.
Yeah.
It's nothing.
Yeah.
Okay, so while postpartum hemorrhage happens in postpartum,
Yeah.
there are obviously things that in labor we can do that increase that risk or
Hmm.
decrease that risk.
Hmm.
And unfortunately, there are some things out of our control that are going to increase your risk
Yep.
for postpartum. Some of the things that
Yep.
come to my mind are gestational diabetes.
Yep.
Bummer. Like it
Yeah.
increases your risk. You didn't do anything
Yep.
to cause it or not cause it. It's just
Hmm.
part of it. Having multiple.
Preeclampsia. Yeah.
Totally.
Yeah.
Preeclampsia is another one. Having
Hmm.
twins or triplets or
Yeah.
quadruplets. Like anytime that you have multiple babies in there, again, you didn't cause
Hmm.
it or not cause it, but
Yeah.
you're at an
Yeah.
increased risk. What are
Yeah.
some other things that we should be aware of that as we're
Hmm.
making decisions or as they pop up in our labor may change our risk when it comes to postpartum hemorrhage?
Yeah, so I mean, like you said, there are lots of things that you can't change. A previous postpartum hemorrhage is also a risk factor, which sucks. I bled all 4 times with all 4 of my births. Yeah, so I didn't need a transfusion or anything, but I had the yucky meds and I had the hammering on my tummy, and so it just happened every single time. So it's a subject to me that is very close to my heart, and my uterus. It's very close to my uterus as well. So things like that you can't change. Placenta previa, a uterine rupture can cause a postpartum hemorrhage as well. So you're at a little bit of a higher risk of that if you've had any uterine surgeries. Your race can actually affect your chances of a hemorrhage. So Asian and Hispanic races are at a higher risk of a postpartum hemorrhage. So that's interesting to know, but just a little
I did not know
little a
that.
little tip a little tidbit for you. And then also things in the labor. So if you have a very long or very short labor, those things can affect your risk of postpartum. And some of that is a little adjustable, right? The very short labor, not really, because if you have a precipitous birth, your baby is coming whether you like it or not. But if we are doing things like adding undue stress to speed up labors by administering certain medications, that could increase your risk of a postpartum hemorrhage. Like we're stressing out the uterus, and then after the baby comes out, we're asking that uterus to do this amazing job of clamping down, contracting down to help control your bleeding, right? But like that uterus has just been through a marathon and has been induced for days and days and days, and you've had this super long labor, it's tired, right? Same thing if we're causing it to overcontract and we're stressing it out that way, then we're also expecting it to clamp down after, and it's tired. It's like I did my business, the baby is out, like I'm good, right? So I think there's some things you can change and there's some things you can't. If you have a naturally long labor, I mean, that puts you at an increased risk. And that's fine. We have to just be aware of it. But I mean, if you're going for an unmedicated birth and you are doing it at home or a birth center, like chances are you don't want to speed up that labor. You want it to be, its natural progression as much as it can be. So just being aware in the back of our minds that the longer it takes, that could account to a postpartum hemorrhage. And yeah, watch out for those precipitous births that come flying in with the baby coming out. They can also be bleeding. Interestingly enough, being a redhead does not actually scientifically proven cause you to hemorrhage more, though anesthesiologists will disagree with me. But I have looked into it. There's no proven scientific data that says redheads bleed more than anybody else. Just so you know.
That's interesting. Although
yeah, I was like,
redheads are a little bit harder to put under anesthesia, I think, because their bodies metabolize it differently. Is that right?
I have heard that, yes. But the only one that I looked into was the bleeding, because I was like, I wonder if that's actually a thing.
Yeah.
But I will tell you this, labor and delivery nurses, if you come in and you're a nurse and you have the nurse curse, we are watching you. And if you're a redhead, we are like, yeah.
Hawkeyes.
We don't care. Scientific data or nothing. We're like, nope, I'm gonna watch you.
All eyes on you. Okay.
Yeah. Right?
Okay, so you saying that you had 4 postpartum hemorrhages.
Yeah.
Is there any data, or maybe it's just a personal belief that's kind of anecdotal? What do you think about some folks having a predisposition to bleeding? Why do you think you bled in all 4?
That's a really good question. I don't actually know if that's a thing or not. I can tell you that I bleed more like naturally, like just with anything. When I get the Botox, I got the little dots. But yeah, I don't know. I couldn't tell you. I don't know.
Yeah, it would be interesting to see if genetics played any role in that. But then also it makes me think that you said, previous postpartum hemorrhage increases your risk. So you had one in your first one. So then it increased your risk if you hemorrhage in your second. Now you have double the, right? Or not necessarily double, but it's a compounded risk most likely. So that is so interesting. Two
We're
things
watching
that
it
we
real
haven't.
close.
Oh, I'm sure, especially with your 4th, right? You're kind of like, all
yeah.
right, what's really going to happen here?
Oh, totally. Yes, totally. And also, if you are on certain medications like blood thinners, obviously that can increase your risk as well, because some people in pregnancy are on blood thinners. And also, they do say that if you have a general anesthetic in your system, then that can contribute to a PPH as well.
Okay. Any other medications that people might be on that might increase that risk of bleeding?
Your aspirins and your blood thinners and things like that. Yeah.
All right, 2 things that we didn't talk about that I want to be sure to mention, just because, again, if these things present themselves in your labor, I want to make sure that you know that you're at an increased risk. And I also want to stop here and say that the things that Tina and I are talking about being at increased risk does not guarantee you a hemorrhage. You can have these things be present in your labor, but not have a hemorrhage.
Yeah. Lots of people too have no risk factors and they'll suddenly bleed, and we're like, whoa.
Yeah. Those are the scariest ones where you're like, we did not see it coming. You had no warning signs, and this all of a sudden you are like bleeding like a stuck pig, you know?
Yeah.
That's the scariest ones. Those are the ones that turn emergent really quickly. Whereas if you have the risk factors, if we can kind of see it coming down the pipeline to you, I feel like the whole room is a little bit more prepared. We're kind of almost expecting it. So we're a little bit, on guard, where when you don't have any risk factors, if you start to hemorrhage, it is a little bit scarier, I think, for everybody in the room. Okay. So those 2 things are pushing for a long time and having any sort of assisted labor. So vacuum or forceps, these things too, you guys are going to increase your risk of hemorrhage. However, with that is usually like uterine atony. So that makes sense that your uterus wouldn't be able to clamp down, right? Because it's so tired, and it made sense that you needed forceps because you had pushed for 4 hours. And now we should not be surprised that your body's not able to kind of clamp down that uterus postpartum.
Yeah, totally. And that can lead into, obviously, if you have any trauma to your perineum, that can also increase your postpartum hemorrhage, because that can bleed quite a bit. So higher degrees of tears have an increased risk, and like episiotomies, you can bleed quite a bit from an episiotomy. Thankfully, we don't do them that often. But with these assisted vacuum or these assisted vaginal deliveries with the vacuum or the forceps, there can definitely a lot of times be trauma to your perineum with that. And so that can lead to sort of adding into more bleeding into the volume that you're letting go of.
Yeah.
Uterine atony, number one.
I mean, it is the reason, right? That is the ugly green monster that's in the room, is that uterine atony. And I think that you mentioning it, we'll get there in a minute because I do have a specific question about it. But you mentioned those uterine tonics and the idea of speeding up this labor is we are balancing speeding up your labor and having productive progress in labor with not overworking and exhausting your uterus to a place where you can't push your baby out, you can't finish labor, you need assisted delivery, you hemorrhage iatrogenic, right? And I think that's kind of my whole goal is I want to prevent the iatrogenic hemorrhages. I want to prevent the hemorrhages that don't have to be and that we accidentally cause along the way by doing something that we might not have needed to do, or we might have had an alternative. So in terms of that idea of speeding up the labor, now we're getting in the weeds of what I call the Pitocin conundrum.
Oh boy.
This is how Pitocin both causes hemorrhage and resolves hemorrhage, right? And it is that delicate balance of if someone needs Pitocin in labor, how do we get them a good dose that is comfortable to them, that's progressing their labor without jumping over that cliff into oh no, we're overworking their uterus, where they then need more Pitocin postpartum. But the data does show the more Pitocin you have in labor, the less reactive your body is to it in postpartum, which then means we need additional support in stopping that hemorrhage, right? And so that's the part where I really am like, oh no, it gets so sticky.
Totally. Because let me tell you something. I'm not at all anti. We call it oxytocin in Canada.
I'm not anti-Pitocin either.
If I ever say oxytocin, people get mad at me. They're like, you're saying it's natural. I was like, oh no, actually, like that's literally what it's. Our vial says oxytocin.
Yeah.
So Pitocin, I think that it can be such an amazing tool when it is used appropriately and responsibly. And I hear a ton of stories of these people who are like, they just hammered it in and my uterus was like contracting. And then of course, baby was upset with it. Like, why wouldn't baby be upset if you're over contracting? But like, I also think people need to understand about Pitocin is that you can absolutely ask for it to be turned down. You can absolutely ask for them to turn it off and give you a break. You can be like, I don't want you to bump it up at this half an hour. Can we wait till the next half an hour? And I always say, like, before I bump it up, I'm like, how are you doing? Are we okay to bump it up? Because I don't take it as like, you gave me consent one time to give you Pitocin. I want you to give me consent every time that you, especially if you don't have an epidural and you're like, we don't want to be just like stressing everybody out, including mom and baby, right? So I think when it's given responsibly, it can be a really good tool. I don't personally necessarily think we always have to like have this aim to get to like the max of Pitocin. Like a lot of times we're like, oh, we're at max, let's go over max, because you can, if your obstetrician gives you the go ahead. But I'm wondering a lot of the times, like, can we get the effect that we're looking for with a lot less Pitocin? And I think the answer is yes, but is it going to go as quickly as it would go if you kept going up on the Pitocin? Probably not.
Probably not.
So I think people need to understand that I feel like they lose a lot of control too when they have to have Pitocin. Like they feel like, oh, I have to have an induction, or my labor was slow, I had to have Pitocin. And it's like, first of all, no, you don't. But second of all, if you do, that's not a failure. It can actually be a really beneficial tool for your childbirth to like have it kind of come sort of the right momentum that we need it to come. And you can absolutely ask to turn it down. You can absolutely ask to turn it off. And if you don't get the right response from the person that's working with you, then perhaps that's not an amazing match for you. And perhaps somebody else needs to come and play with the Pitocin module. Because I don't know. I feel like there are just better combos than just hammering up on the Pitocin, just till the max, just because we don't know what else is happening personally.
Yeah. I don't know if you have this phrase in Canada, but in America, we call that pit to distress, and we just pit them until the baby is in so much distress, and then it's obviously a C-section. So I know that that's something that a lot of our nurses are working towards education on and just using that Pitocin strategically, right? Like just because you're there for an induction, A, it doesn't mean you have to have Pitocin, and B, you don't necessarily need to start there. Maybe we start with a cervical ripener, maybe we start with a balloon, maybe we start with a combination of one of two of those. Maybe we break your waters and add a low dose Pitocin. It's really interesting to hear you talk about turning it down and off, because I think that for our team, it's something that we educate all of our people on in the birth lounge, in our one-to-one clients, but that is where we face so much pushback in the hospitals.
Oh, 100. I get pushback when I turn it.
Really?
Yes.
Really?
But it's like, it's because why did you do that? Because the patient asked me to, because the patient didn't want that much. Like, I don't know. I think we lose sight of the fact sometimes that, like, even if you're contracting 3 in 10 minutes and not 5 in 10 minutes, just because we're not at that textbook 5 in 10 minutes, does that mean that we're not still making change in that cervix while still allowing mom to rest and the uterus to rest and the cord to refill and reperfuse baby? Like, I don't know if we always need to, like, aim to have this, like, boom, 5 and 10, you're there, boom, this is great labor. Because I don't know, sometimes it's not great labor. Like, we don't really do that pit to distress. Well, I don't usually see pit to distress, and I'm not saying it's a Canada-wide thing. I'm sure that it's got to be obstetrician dependent, I would think. And I'm sure that there are places in the States where not every obstetrician is like, I'm going to do it. And I'm sure there's lots that don't do it. But yeah, I think people need to know that it doesn't have to be like, boom, you're in labor, like, holy Moses, because that's what you hear all the time is people are like, holy, I had Pitocin and it was like, it hit me like a ton of bricks. And I also, personally, if I were, like, was Jen Hamilton always say, thicker than a Snicker? If my cervix was long and thick and hard, like, if you jump to Pitocin, all you're doing is you are hammering that baby down on a brick wall. Like, nothing's going to happen except baby's going to get distressed, right? I don't know if I personally have ever seen somebody who is closed or thick or whatever it is get Pitocin and have it go well, because, like, that cervix is not going to move. Like, the purpose of Pitocin,
you're skipping steps.
give you that
like you're literally
is to give you those
steps.
contractions, to bring baby down on a cervix that is soft and flexible and stretchy, because then you bring it down and then your cervix is going to do more changing, right? And when you bring a baby down on that soft cervix and it's changing, you're going to get your own oxytocin going. So maybe you don't have to go up on the Pitocin as quickly, because now you have a cervix that's doing what it's supposed to do when the baby comes down on it, and we can have like a little bit more of a progression that we might want to see that's more helpful than harmful. So yeah, I would personally, it wouldn't be like, if somebody was like, how do you want to be induced? I'd be like, what is my cervix saying? Because that's going to depend on what I want.
Yeah, absolutely. And you guys, if you are looking at an induction, scroll back. We have several episodes that deal with induction. We talk about out of hospital induction methods, meaning that you're working with your hospital and then they send you home. So there are some outpatient is what it's called. So it's not at home induction. It's not natural remedies, but it's outpatient. We talk about different methods that you have. And then I have a midwife Becca Healy, who talks about the data between breaking your waters and adding Pitocin at the same time around that 4 centimeter mark. That's some really interesting data too. So you guys scroll back and check that out. So
I'm going to scroll back and check that out too.
Yeah, they're so good. Also, I re-listen to all of our podcast episodes just because I feel like in this moment when we're recording, I get to soak up a lot, but there's so much that, my brain is other places. I'm taking show notes, I'm doing timestamps, I'm making sure to capture quotes, and I'm making sure that I'm capturing all the good pieces for the descriptions and stuff. And so when I re-listen after the podcast airs, I always learn something additional, and I'm like, oh my God, this is such a fun interview. It's just always
I love that. Do you listen back and you're like, dang, I'm smart?
Not really, I'm smart, but I'm like, dang, that was a good conversation, or dang, that guest was just like so good. I get to meet some of the coolest people on the show, and so for that I'm very, very grateful.
That's amazing.
So I think the question now remains, if we do have a hemorrhage, what are the resolutions? What medications, what protocols, what tools do we have? And maybe we could start kind of low totem pole to go all the way up to the most maybe invasive method.
Why don't we start with, like, let's run through it. let's run through it. Let's say you had a baby and you start to bleed, like what's going to happen, right?
Yeah.
So a couple things happen sort of simultaneously. The first thing we're wondering is, what is your uterus doing? How does it feel, right? So we talk about, you'll hear the term a boggy uterus, right? So this is going to mean your uterus after you give birth should be hard, like firm, hard, right? I should be able to feel it in your belly. It should be hard, okay? Sometimes I'll feel a uterus and it's soft, feels like a cushion, okay? And that's called a boggy uterus. So that means uterine atony is going on, meaning your uterus is not working. It's tired, it's over it, it's done, right? And that uterus actually responds to physical touch. So one of the first things that's going to happen when they do a fundal check, and that's different than fundal massage. That's also something I hear all the time, fundal massage, fundal check. I'm going to say, oh, that's a little bit soft. Mom, I'm going to give you some fundal massage, okay? Fundal massage sucks. It is not nice. You have a uterus that is sore and cranky that did all this amazing work, and now we're going to squeeze it. So your nurse is going to get on top of your belly, well, with their hand, not their body. They're not jumping on you. Please don't think that. And then they're going to massage your uterus, just like it sounds, but it's really firm. And the idea is when they touch that uterus and they massage it, it's going to firm, it's going to contract down, because the uterus is trying to contract down to like cut off that bleeding from that placenta that's just separated from that uterine wall, right? It's trying to come back down to pre-pregnancy size and control your bleeding. So that's what we want. So they're going to massage your uterus. And a lot of times that works. It works really well. The other thing that we're doing, usually a second person will be in at this time, or your baby nurse that was there for your baby can do this. We're probably going to put in a Foley catheter or trying to empty your bladder. And a lot of people are like, well, why do I need a Foley catheter if I could just go pee? That's because, I mean, you may not, you might be able to like lift up and go pee on a bedpan. But what we need in the case of a hemorrhage is we need almost an empty bladder, because in our abdomen, we have a bladder and we have a uterus, right? And they're sort of fighting for space. And if this bladder is super full, the uterus doesn't have as much room to contract down. But if the bladder is empty, it's got all this space to contract back down, right? So if we get the pee out of the way, that uterus has the most ability to clamp and contract down and control that bleeding. So the other thing is we want to get rid of the pee. A lot of times that's a Foley catheter. You could always ask to try a bedpan, but I don't know. I sort of feel like in an emergent hemorrhage situation, it's probably going to be a Foley catheter. So just a heads up, right? Those are the two things that usually work really well, okay? If those things are not working, we're going to be looking into medications. And there's a whole slew of medications. And I'm pretty sure that different facilities or different countries have different orders that they do their medications. The best thing for you is going to be IV medications. Those work the quickest, okay? But if you do not have an IV in place, it will be put in immediately, like as these other things are happening. This is kind of a hill that I die on a lot, is that personally, I would never personally have a baby without an IV in place. Obviously, because I've had 4 hemorrhages, but also because I have personally seen how much blood can be put out of a woman's body in a very short period of time. Now, I don't mean like you need
risk factors.
Yeah, without any, it can just fly out. Now, that's not to say that we're not skilled professionals who can get an IV in fairly quickly.
Totally.
But I always say, like, even those few minutes, because we're not talking seconds, like to get an IV in, to like get the line, get all the stuff, to put the tourniquet on, to wipe the vein, to find the vein, to put the needle in, to get the thing. That's, I would say, even the fastest person, that's like a minute and a half, 2 minutes. Fastest IV starter in the West, sort of thing. And you also have to take into account that if you are bleeding, now these big, beautiful, like puffy veins, they're flatter, right? Because you're losing blood volume, right? So they're a little bit harder to find. Usually with pregnant people, it's not as tricky as like an elderly person who is bleeding, right? Like you usually still have enough blood volume that they puff up okay. So you have to take that like minute and a half, 2 minutes, the best IV start, and like sort of add a little bit of time. So you're losing time. Are there things we can do in the meantime? Yes, we have medications we can give intramuscularly, but the fastest effects that you're going to see from a medication are going to be IV. So you're looking at uterine massage, a Foley catheter, and an IV if you don't have one. Some sites, once you start to bleed, will actually have a protocol that they put in 2 lines. Okay, so if you had a line and they have a protocol where they want 2 lines, that could be happening as well. Sometimes an anesthesiologist will come in and do that for you, because there are certain medications that don't mix. And so sometimes they want to be able to give you 2 medications at one time. So there's a bunch of different medications. Your Pitocin is like one of your first ones that you're going to go to. It's usually in an IV bag. It is usually flowing in wide open like a waterfall, because we want to just give your body all of the oxytocin that we can. There's other ones that are pills. They can go in your bum. There's some that can go in your muscle. So different medications for different sites. And I'm going to tell you that they all have really gnarly side effects. That's the thing I tell everybody. Like these meds for postpartum hemorrhage, yeah, they just have really bad side effects. I mean, the alternative side effect is that you're, bleeding profusely.
That you're dead.
Yeah, that's the alternate worst
The
side
other
effect.
alternative is death.
It has a black box warning for dead. That's So I can tell you the ones that I've had.
Like what kind of bad side effects are you talking about?
Like one of them, like the misoprostol can cause you to shake really bad. Like you want to like vibrate right off the bed. We have another one called ergot. I think it has a different name in the States. That one can cause you to like vomit violently. There are some that cause you to poop violently. So depending on how many of them you need, you're in a pretty rough state. Like probably to the point where you aren't even wanting to really snuggle with baby, which sucks because that's like supposed to be a beautiful, and that's, I think a lot of people have trouble with that, like a severe postpartum hemorrhage. You have just people everywhere and you feel like crap. And so a lot of times baby is with a partner who is sitting on the side, usually look with their eyeballs like this because they're like, what is happening, right? So I think that's important to be aware as well, that partners also educate themselves on these types of things, because it can be like, I think birth on its own is sort of eye-opening for partners because they're seeing their partner in a state that they've never been in. They're seeing things they may not have ever witnessed. They're smelling things they like. It's a whole thing, right? It's not just like you see it, like you smell it, you hear it, you feel it, right? Like there's vibes that you're feeling. And so I think that can be really startling. So I always try to make sure if it's not me, somebody is with partner explaining to them what's happening, right? Because that's a lot. So yeah, so for me, I was like vibrating off the bed and throwing up. My nurse said, she's like, here's your med, here's your bucket. I said, thanks so much. And then I immediately said, honey, take this baby. And I just handed the baby off and was like, oh, like it was terrible. But my bleeding stopped and we didn't have to progress down the line. So you win some, you lose some, right? I think the whole idea of these first sets of things that are a little bit less invasive, not that meds are not invasive, is that you're not progressing to these more invasive things that you're going to need to do to control your bleeding. So hopefully sort of fluids, meds, a catheter, some fundal massage kind of fixes things up and you're going to feel pretty crappy, pretty heavy, but you're not going to be bleeding. If it's not working.
Before you move on to other like higher level things, can you talk to us about the medication Methergin? This one goes in your butt. Is that right?
Yeah, I want to look it up because I was reading about it. We don't have that one. And I'm wondering if that's like our ergot. And that's what I'm wondering because I was looking up, our protocols are a little bit different in Canada versus the States. Sure. And we've actually just come out, like where I live, with new guidelines as to what meds should be given in what order. And whereas like the one that we used to give all the time was actually your Cytotec rectally. But now that one's like the last thing you're supposed to give. And then I read somewhere else you're not supposed to give it rectally. And so I'm like, it's a little schmozzled. And I find that providers, even with protocols in place, will have their favorite medication that they're confident in, that they've seen success with, and they'll give that first. So yeah, so there's a few of them, but I don't know that one. And I don't know if it's
and it is the same class of medications as, are you saying ergot?
Ergot, like ergot. And so we give ergot. We used to give it half IV, half IM. Now we give it all IM. Yeah.
Oh, okay. Yeah.
So we don't give it in the bum. Yeah.
And you don't give it through an IV if they have an IV. So that person has an IV place and you're also giving them an injection intramuscular. Yeah. Is that right? Is that in your leg or in your butt cheek?
Usually in your leg, in a nice big fat leg. Yeah.
Yeah.
Yeah. Yeah. So we usually give like the Oxy IV. You can give like tranexamic acid IV. And then there's other ones like your IM medications. Okay. And then there is your ones that can go in the bum at the sort of towards the end of it. Yeah. Yeah.
And does it matter? How do you determine which one? Is it based on the hospital protocol, and that's based on how much someone is bleeding and how much we're able to manage it?
Yeah, it does. Like where I work, there's like a sort of a simmer down. So it's like the first stages you're going to give like a bolus of Pitocin, and then you can give this tranexamic acid, and then if that's not working, you can move to the next ones, and if that's not working, you can move to the next ones. But also there are certain medications that can't be given with certain conditions, so that's something to be aware of as well, like things like high blood pressure or things like asthma. There are certain medications that you can't have because it can make those symptoms worse.
Totally.
So also things to think about, because the last thing we want is for somebody to be bleeding and then we give them a medication and their blood pressure is now like 280 on 150, and now we're worried about them having a stroke on top of the fact that they're bleeding, right? So yeah. And that's that ergot. You can't give with high blood pressure. Yeah.
Oh, got it. Okay. All right. So now we have what? Intrauterine devices would be next.
Yeah. Yeah, actually, bimanual massage might be next, which is
Okay.
just a treat, just a real treat. So that is like uterine massage from both sides, from above and inside. So
Oh,
this is where things can get like real hectic, real uncomfortable. At this point, like this is something also I want people to be aware of. If you don't have an epidural, this stuff is intense and powerful and overwhelming and very, very uncomfortable, as well as it probably feels pretty invasive, feels maybe a little bit violating, because now you have somebody on top of your abdomen, and also they have their whole hand kind of up inside your uterus and they're sort of massaging it from both sides, which you can imagine without an epidural would be pretty intense. So this is where you want to be advocating, if you're a nurse or even maybe if you're a doula or a partner, to be like, hey, because sometimes I think these things happen really quickly, and we know the effects of a prolonged hemorrhage and how hard that can be to sort of reverse. So I think sometimes, and because epidurals are so common in hospital, I think a lot of people just forget that some people don't
mm-hmm.
have them. So this is
Mm-hmm.
where things like your nitrous can be really important,
Okay.
to be giving them, or a dose of IV narcotics, because at
Okay.
that point, like, we're concerned more about their comfort and getting them well. So yeah, I think that that's important
And
to
you can
remember.
ask for this if you're a patient. If
Absolutely,
you're like, this is
absolutely,
unbearable, I need some
yes,
medication, you should ask your nurse or your doctor to give you
100%.
something.
Yeah,
Cool.
yeah, if you're able to, 100%. I usually like dole this one to like the staff or the support people, because a lot of
Yep.
times the patient is so like, it's like there's just like IVs going
Yep.
and people talking and it's loud and you
Yep.
don't, it's wild. Yeah. So yeah, if someone hasn't thought of it, it's really important because it can be really intense.
Yeah.
And then yeah, then you're going to your internal like mechanism. So you guys in the States have the Jada,
Yeah,
which
we
I am
do.
hoping somebody at A1 has one. I want to see it.
They
I
will
actually messaged
be. That's where I learned about it last year, was at
I
A1. I got
I
to play
messaged
around
them
with
and
it.
I called them. I was like, "Are you in Canada? And if not, can I bring you to Canada? Like, I want you." And they're like, "No, we're not in Canada yet." It's like, oh my God. So these are devices that are put inside the uterus to try to fix the bleeding from the inside before moving to like a surgical effort, which is going to be your last ditch, right? So here in Canada, and you before Jada, you guys had a Bacri. Okay, that's like a balloon kind of like this, and it's going to go inside the uterus, and then we're going to inflate it. So it puts pressure on the walls this way. Okay, so it's trying to control the bleeding this way. That one stays in, I want to say 24 hours. I want to say 24 hours. And then you guys have the Jada, which is a similar shape, but it sucks the walls of the uterus down, I believe, right? And that one can stay in way less time. I think it's like 4 hours, because I'm like so in love with it that I want to see it and buy one for myself to play with. Yeah, so that's supposed to be an amazing tool. So I would love to see that come to Canada. And then after that, it's surgical. So it would be like you would be put out, and they could put a stitch on the uterus. I always say it looks kind of like a turkey, but
Okay.
they sort of wrap the uterus in a stitch. It's called a B-Lynch suture, and it kind of squeezes the uterus like this. And then the last stitch would obviously be a hysterectomy, which, I mean, you would hope that every provider would try to avoid where at all possible. Yeah. So it's
Yeah.
sort of like this, like, yeah, this waterfall effect of things. So that is the reason why it's so important to be aware of how people are feeling and how much they're bleeding, because if we can see it and identify it before it becomes a larger problem, we can avoid a lot of these more intense interventions down the line.
Yeah.
Maybe you can just do a catheter, some massage, and a medication, and it firms up and things are going well. And I think the other thing we should talk about is waiting. Sometimes the balance between like needing to wait and needing to act, maybe we need to look at with a little bit more of a magnifying glass, because sometimes we don't necessarily give those interventions time to work, right? You're
Mm.
supposed to sort of see how they work. And I always think about it like in CPR. Like when you're giving CPR and you hammer in a medication and then you immediately check a pulse, like but you haven't actually given that medication time to do what it needs to do to help that pulse. So if we hammer somebody with a medication, we wait 1 minute and then we're like, oh, it's still soft. Hammer them with another one. Wait 30 seconds. Oh, uterus is still soft. Hammer them with another medication. Then all of a sudden they feel like garbage and their uterus is like rock hard. So it was very effective. But you have to wonder yourself, was the bleeding severe enough to warrant like not giving it that little extra time to see if it was an effective intervention? Because I find that a lot of hemorrhages are resolved, thankfully, with a few interventions that seem to work really well. So yeah, I sort of have to think we really need to see how the hemorrhage is going, how intense the hemorrhage is, and like, do we need to like go all the way down, the Grand Canyon, or can we just sort of like wade in the pool up here a little bit? then maybe go down to like where it's covering our nips, and then dive right in after that,
Yeah.
like let it simmer.
I mean, I think you hit the nail on the head when you said it's a balance, right? And it's a balance of a lot of things. So knowing, I know you're in Canada, but it could be the same in Canada. We know that one of the biggest challenges, and I don't know how to say this nicer, killers of postpartum women is postpartum hemorrhage.
Yes.
We know that this is something that historically and traditionally our country has struggled with. And so I think that healthcare providers bring a lot of trauma themselves of things that they have seen and things that they never ever want to see again. And they know that they have the tools and the answers to fix this. And so it is that balance of checking yourself and saying, okay, I'm freaking out and I know where this might
Where
lead,
this
but
can
I
go.
might need to give an extra 30 seconds to take some deep breaths and see if that extra bolus of, Pitocin is going to do its job, if that fundal massage is going to help activate that uterus and get it to clamp down. I'm really blessed as a doula that I don't carry that same trauma. I've never been responsible for that kind of stuff. I have been in rooms where they've happened. I've seen so many hemorrhages. I do feel like I could manage one. I've seen so many of them, but it's a different type of trauma actively caring for someone versus being a doula and just witnessing that. And so I do want for listeners for you to hold space that your medical providers do come with trauma to your birth of things that they've seen and things that they want to prevent from you. And so I don't think, and we talk about this all the time on this podcast, I don't think anyone comes to medicine with malintent or wanting to cause harm. But I think a lot of times medical professionals aren't doing their own inner work and getting therapy and managing their own traumas. And it does sometimes bleed over into the care that they're able to give to their patients. And so I think it's just that balance. I think it's just finding how do we balance the things that are going on in the room to give this person the best care and also protect ourselves as the caregivers, right? Because there is a piece of it where you're like, I don't want to see this person hemorrhage because that's going to be a horrible day for me, right? It's very traumatic to see the human body do something that it's kind of really not meant to do.
Yeah, it is super intense. And like, don't get me wrong, there are times where that it's going to very quickly become a very large problem. Like there are times where you put the catheter in, you have the ID, you give the fundal massage, and that uterus is just simply not responding. It's so soft. It is, and you give a med and it never firms up. And so in those instances, yes, do we need to be super, super quick and super forceful? And do we need to be like bang on top of it, or this is going to go real bad real quick? Yes. But are there situations where they're bleeding more than we would expect them to, but like, could these interventions be effective? Also, yes.
Yes.
I think there's definitely times where it's warranted to be like super aggressive with your treatment. 100%. You know what I mean? And you have to hope that you trust your provider to provide you the best care. And these are things you can talk to them about, like in your prenatal appointments, right? You can be like, how do you manage postpartum hemorrhage? How many postpartum hemorrhages have you seen? Like, what could I expect if I did have a postpartum hemorrhage? Like, I would want to know, sort of the way that they approach it and how intense they are about it, and how many experiences they've had with it.
And maybe that hospital's protocol, because you mentioned that everything changes. So maybe you're curious about the medications that you would receive. And if you do have any of those conditions or are on any of the medications that we mentioned earlier too, have that conversation. Your doctor already knows it. It's in your chart. It's not like they don't know it, but maybe it would bring you some comfort to know that you've had a conversation with your provider about this, just to help you kind of understand what would be your experience if you did have a postpartum hemorrhage. Okay, so can you tell us the difference between a fundal check and a fundal massage? Because we briefly mentioned that they were different, but in what way are they different?
I don't think people realize. So everyone's like, why you got a hammer on my, actually I just did a video about this because they can feel like you're in a wrestling ring, like, why are you touching me so firmly? But like a fundal check, I think it's necessary. I think of it as a postpartum vital sign. So we look at how you're feeling, we look at your vital signs, and then I don't think that your postpartum check is really complete if I have no idea what's happening with your uterus. So that fundal check should just be a gentle check, and people are going to like roll their eyes when they listen to that. Should be a gentle check where your nurse or whoever's caring for you sort of is just squeezing the top of your uterus And they're doing it for a couple reasons. They want to know, where in your belly is your uterus? If your uterus is moving up and up and up and it's over your belly button, we're sort of thinking to ourselves, is that uterus being nice and firm? And maybe is it filling up with blood? Because if it's moving up, we're thinking that it's not really doing the contracting and it might have lots of blood in it because it can't control that bleeding. We also want to know, is it left or is it right or is it center? If it's moving off of center, we're thinking about your bladder and how your bladder is probably in the way and maybe we need to get rid of it. We also want to know, when we give it that gentle squeeze, what comes out? Does a little bit of blood come out? Does a huge clot this big come out? And do we need to then kind of investigate further? So that fundal massage doesn't have to be rough, but it can provide so much good information on what's happening in your uterus immediately postpartum. So I think it's like, it should definitely be part of your postpartum vital signs. And it's different than a massage. That massage is purposeful. It's a treatment for postpartum hemorrhage. Yes, it's rough. Yes, it's hard. Yes, it doesn't feel good, but it's actually like a medical treatment for a problem, which is your uterus is not contracting and you are bleeding. So they're very different. They should feel different. Should we be running into everybody who had a straightforward vaginal birth and being like, I'm going to check your uterus? And no, like that's not necessary. We do this after C-sections too. That surprises people to find that we do actually check your fundus after a C-section. People have thought that we're not going to because you have an incision. It's a little bit different in that you're supporting that incision when you're doing that fundal check, but still you can have a postpartum hemorrhage following a C-section. It can be the exact same thing because you're having uterine surgery, right? So it's important.
And what should we be seeing when you're doing the fundal checks come out of us? We are expecting some blood, we're expecting some clots, but what does it look like? What does it feel like? And then what would indicate to you as my nurse that something is problematic?
So the blood should be a little bit thicker. Like it shouldn't be, if it's bright, like bright red and it's watery, almost like water or like soup, we're thinking, that is not something we would be expecting. It should be a little bit thicker and a little bit darker, and we shouldn't be seeing those huge clots come out. We might see one. So sometimes, and this is where you have to take a whole clinical picture. Sometimes everything is fine and they feel great, and you push down on the uterus, it's a little bit soft, and you express a very large clot. And then the uterus is firm after that. So sometimes something happened and the blood was pooling in there and you express it and the uterus now has all that room and it can clamp down and it's happy and it's lovely. And at that point, personally, I would let the provider know, hey, I got a big clot out. It feels great. The flow coming out now is dark. It's a small amount. It's not saturating the pads. And they'll usually say, okay, just keep monitoring. You might want to check at 10 minutes instead of 15. I would. But do you need to jump again to like hammering them with medications and putting in the catheter? Maybe not, right? If you're doing checks and lots of clots are coming out, lots of checks in a row, that's again something. So I think it's important to just like use your thinking cap and take the whole clinical picture in, and just to be communicating with the people who are ultimately in charge of that person's care. But yeah, it shouldn't be saturating pads. It shouldn't be bright and watery. It shouldn't be having multiple big clots coming out. And interesting to know too, when clots come out, a lot of times we'll actually break them up because we're concerned about retained placenta, right? So if we take that clot and it breaks up, we know that it's not tissue. If we take that clot and it doesn't break up, we could be thinking maybe there's a retained placenta and maybe that's why they're throwing clots or they're bleeding more heavily. So yeah.
Totally. And how often are we having these fundal checks postpartum? Does it matter if you have Pitocin versus not?
No. Well, again, that could vary site to site. Where I'm at, it doesn't actually matter. The protocol is like every 15 minutes after a vaginal birth or every 10 minutes in recovery after a C-section. And you do that regardless. Again, those could pick up if you are having heavier bleeding or more clots. And that's usually, again, every site's different. Mine is like there's 4 15-minute checks after your birth. And if all of those checks are good and the uterus is firm and the flow is, a minimal amount, it's not increasing, it's not getting more watery, then you would be safe to become then a postpartum patient where the checks are a little bit less frequent.
Okay, cool. Wow, so interesting. Okay, now hearing you talk about fundal checks versus fundal massage makes me want to make a key point here, especially to American listeners. We have a lot of things on the internet that says if you get postpartum Pitocin, you don't need the fundal checks postpartum, the fundal massage. And I do know that is what the data says. It does say that if you get Pitocin, there's no additional benefit to uterine massage, but that does
Interesting.
not mean uterine checks.
Right.
And a lot of
Right.
people get that confused. So they think if I get the Pitocin, then no one
You
has
ain't got to
to
touch it.
touch me.
You ain't got to touch my
Exactly.
uterus.
But that's not what it is. It's get the
Oh.
Pitocin, and I still need to do these 4 incremental checks in that hour following birth. I just won't have to actually massage your uterus.
Right.
So if you're listening and you thought, I'll just opt for the Pitocin and then nobody will have to touch me, it's not quite like that. It's not quite as bad as getting multiple fundal massages either.
Yeah.
So it is a happy medium, but I understand some people choose the Pitocin because they don't want to be touched postpartum,
Oh
and it
boy.
won't quite work out like that. It could for sure, but you are just assuming a little additional risk because you're not letting your nursing staff kind of touch your uterus and check for that bogginess.
Yeah, totally. And you know what? That could, I would think I would be willing to bet that even with that data, and I don't know how nurses there are trained, but even with that data, if somebody's uterus was soft like a cushion and it was boggy, I'm willing to bet that they would probably still try to do fundal massage.
Oh,
It
definitely.
just feels like a next thing that you go to. That's interesting. I want to look into that now. Yeah, that's really interesting.
Yeah, I think that's for firm uteruses. So if the
Hmm.
Pitocin is not working and you still
Yeah.
have that boggy uterus, that would let us know
Hmm.
that that dose of Pitocin was not effective, right? And you
Hmm.
probably
Yeah.
do need to opt for something a little higher on that totem pole
Right.
that we had kind of talked about earlier.
Yeah, yeah, yeah. The whole aim of giving you Pitocin postpartum is to help firm your uterus. I mean, you would hope that that is doing what it should do, right? I mean, that's the whole reason that you
Totally.
say, yeah, I'll have that medication. Yeah, yeah.
Totally. I find that this one is a really tricky one that people get really hung up on. Pitocin does get a bad rap, and people
Hmm.
really they want low intervention. I'm just not always convinced that that's the intervention that you want to go low on, that you might want to,
Hmm.
ditch. There's a ton
Yeah,
that you could ditch. The
yeah.
postpartum Pitocin one is so individual. If,
Hmm.
it is a standard of care for a reason because we know it works. We
Hmm.
also know that expectant management is definitely a thing and certainly a
Hmm.
safe alternative, but it's very individualized. I think going in with your mind made up like, yes, I'm getting the Pitocin, or no, I'm not getting the Pitocin.
Yeah.
I think it is a disservice to you, and I think you really should go in with an open mind of, here are the situations that I know Pitocin would be appropriate, and
Right.
here are the situations where I would rather, I have a preference for expectant management.
Right.
And I'm going to talk to my healthcare providers about that if I'm in these situations.
Totally. And yeah, and I think it's important to, like, I mean, if I always say, if you want to not have it, if you want to say, I don't want Pitocin when my baby comes out, or I don't want Pitocin, or I don't want an IV, I mean, that's totally your call. And I'm happy to do that for you. I'm happy to say absolutely. But I want to know that you understand the risks. I want to know that you understand why we wanted to do it in the first place. And
Totally.
then I want you to know, like, the risks of not having that. And for me, like, I like to explain to people, like, listen, I understand having an IV with like a tube attached to it, for some reason that feels immediately confining. Like, anytime I've been in the hospital, I've been fine just waiting for the doctor, and then they're like, we're going to start an IV, and like immediately I just feel like I can't get
You're like, okay,
comfortable.
now I live
I just
here. Now I'm
I
trapped.
don't know. It's this weird thing that happens, even though it's really just a tube attached to a pole, but it just feels confining. I get it. But like, I want to explain to you, like, did you know that you can have an IV without the tube attached to it? If you're
Yeah.
drinking in labor and you're able to keep fluids down, then really you are able to take in the same amount of fluid, if not more, every single hour that I could give you in this bag of fluid. And so you could have that somewhere here, and we could even wrap it with something soft so it's not bothering you. But in the case of a hemorrhage, boom, it's there. We can give it to you immediately, right? We don't have that delay in treatment. So I just want to make sure that people understand that it doesn't have to be. And you know what? Actually, people have told me that the protocol is to have an IV and to have fluids running. So yeah, I would also challenge people to see that protocol if it's something that
Yeah.
they don't want. But I always want people to know, like, listen, you can absolutely have an IV in place with a saline lock on it, just a little tube, wrap it up. It's there. It's out of sight, out of mind. You're not attached to anything. You can move around. There's no limitation in the amount of cord. You don't have to feel cold fluid going in your arm if that bothers you. Like, there's just a million things you could do, and it can still be comfortable, but you can also have that sort of in place. So yeah, I just want to know that people understand that it doesn't have to be as confining as they think it might be. It doesn't have to be as big of a nuisance as they think it might be, and the importance of having that ready to go. And you know what, if you understand that and you're like, no, like this is a physiologically normal thing that I'm doing, I don't want that at all, it is completely against my wishes, then I say, as long as you understand, I am totally fine with that. And you know what, just because you don't have that IV saline lock in place, it doesn't mean if you hemorrhage, I'm going to feel any sort of way and not do my best work the fastest that I can to get that IV in place and call all the people in that I need it. That's not what that means at all. We just want to make sure that you have all of the information to make those choices the most effective for you and your birth.
Totally. Okay, so talk to us about this. This is a question that I always get. Well, if I don't have an IV, then they
Mm-hmm.
should just be able to give it to me in an injection. Now, one
Mm-hmm.
thing that you've already mentioned is that the fastest way that something gets
Yeah.
into you is through your bloodstream. So that's IV. Is that
Yeah.
a main difference when it comes to medically managing postpartum hemorrhage? Is that it's just the fastest line is through
It
IV.
is
So
the
giving it
fastest.
IM is just going to be a little less effective
Mm-hmm.
because of the
Yeah.
time.
Yeah, totally. So
Yeah.
when you give it IV, it goes like right into your vein, right? When you give it IM, it's going to all those little blood vessels, which is slowly kind of trickling into your main circulation, and then you're seeing the effect of the medication. So we have to think that there's going to be a delay of onset by like 10 minutes, maybe. Like,
Wow,
depends on
that's
the
a
medication.
lot when you're bleeding.
Right? Yeah. Even 5 minutes is a big deal, right?
Yeah.
And you'll start to see those, but like the main effect, like the peak of the effect of the medication, is going to take even longer than that, right? So when you think of it, I mean, it can be definitely a nice thing to give, so you have something going into circulation while you're
Okay.
working on getting an IV. But I can tell
Okay.
you, 100% of the time, if you're hemorrhaging, one of the first things that we will do is put an IV in.
Yeah.
It's just, yeah. I mean, unless you refuse it, in which case we'll say, well, you're actively bleeding. I'll do everything else I can in the
Totally.
meantime. It's probably already happening, actually, all the other things we can do. But at that point, it would be stressed how important it is to get IV medications in.
Yeah. I mean, the risk
Mhm.
is just so much greater, right? If
Yeah.
you're
Yeah.
actively bleeding, like you are taking
Yes.
on just so much more risk,
Yeah.
which again, like you, if you're okay with
Yeah.
that, then I'm okay with that.
Mhm.
But I do think that sometimes, especially with social media the way it is, people make decisions
Mhm.
and don't truly understand the full risk.
Yeah.
And to no fault of their own, our healthcare system is so broken and backwards that people are really kind of grabbing at any information. And we
Mm.
would hope that we would have a space that we could have open conversations and truly talk about kind of transparently benefits and risk. And I know a lot of people they don't have that opportunity. And I don't
Yeah.
think that it's your fault, but I do think that it's really important that if your healthcare professionals are saying like we're really stressed about this, we are very concerned about this, at least hear them out and say, okay,
Yeah.
explain to me why. Help me
Mhm.
understand what you would be doing this for and why you would be doing it and why it's so important to you. And then I get to decide
Yeah.
whether it's important to me or whether I'm willing to take on the risk that you're saying are
Not to be.
associated with this. Yeah, absolutely.
Yeah, and I always say to
Sure.
people, this is why I think picking your provider is super important. And I know that not everyone has
Yeah.
access to even a provider. And then on top of that, maybe they don't have, the opportunity to switch providers. But I always I'm kind of glass half full girl most times. And I like to think that if your provider is suggesting something, they have your best benefits and the best outcome for you and your baby at heart. Like,
Yeah.
I like to think of it like providers are in this line of work who enjoy their job and enjoy helping people. They really, hopefully, are making suggestions on things that are really going to help you and help your baby and help you achieve the goals that you set out. Are there bad providers? Yes. Are there bad teachers? Yes. Are there bad police officers? Are there bad nurses? Yes, yes, yes. Right? There's always people who you're like,
Bad doulas?
why you do
No.
why you do this line of work, right? But we have to sort of think, if we find somebody that we vibe with, that we connect with, I think that's the reason that you trust them and you put your trust in them. And so when you're seeing things on social media, it's so important to take it as a conversation starter with your provider. Like, don't take it point blank, on regardless of whose platform you see it on. Take that piece, take it to the person that you have entrusted with the care of yourself and your baby, and use it as a conversation starter. Hey, I heard this here. What's the deal with this? Is this true? Is this not true? Like, please don't take medical advice on social media. I mean, yeah, at point blank, because it can be really, really dangerous. And we've seen it time and time again, especially in the birth setting, of how detrimental misinformation can be in a birth setting. Like, it's not something that you want to look back on and say, I wish I hadn't done that because I heard it one time on so and so's platform.
Yeah, I think there's a bigger issue at point here is that social media is not the place to get your medical information,
Yes.
right?
Yeah.
Like it's just
Yeah.
not the place to do that. So
Yeah.
what is causing people to seek medical information in other places? And I think that has a lot to do with our healthcare system is not set up to give people the information and support that they want. And so, like I say, they're grabbing at straws, trying to get information that helps them feel better and make decisions and feel in control. But 90-second clips will
Yeah.
never, let me say it again, never suffice for a full conversation, for a full childbirth ed class,
Yeah.
for a full childbirth ed course, for a
Yeah.
true transparent conversation with your provider that knows you, that has been with you through your pregnancy. 90 seconds on social media is never going to be the same as that, you guys. And so the real problem, exactly, for the people in the back, it really is, you cannot get your medical information from TikTok. That's not how the platform was designed, and it's not how it should be used. And the only person that's going to pay the price for that is you. And so, we say this with love, and we say this as people who educate online, and we want you to be taking our information, but it's still not medical advice. It is thought pieces. It's education to get you thinking, to get wheels turning in your head, to get questions down on a notepad so that then you can take them back to your provider and say, hey, I saw this on TikTok and I would love to have a conversation of if it is applicable to me. Hey, I saw this on TikTok and I would love to have a conversation of if this pain relief option is offered at this hospital. Are you familiar with this? What is your practice? How often do you do this? Yada, yada, whatever it is.
Yeah. Or I have this medical condition. Is this safe for me in my pregnancy? Because we forget that it's like not everyone has the same pregnancy. Not everyone has the same medical background. Not everyone has the same genetic conditions, right? And so, yeah, it's really dangerous when you're just taking things like a blanket statement and applying them, willy nilly, right? And I wonder if doctors ever thought that they would start their appointments with, "I heard this on TikTok. Is this true?"
I don't think they do.
Where are we? It's like 20.
Yeah.
It's wild.
I think our doctors are so caught off guard, but I do think that your more progressive doctors realize why people have turned to TikTok, and I actually don't think that they're offended by it. I think your progressive providers can see the benefits. So there's actually really good studies that say good information and patient confidence has gone way up since social media has become a thing. The problem is being able to decipher out misinformation versus evidence-based. And that's where we really struggle. And that's where the algorithms really fail, is because it boosts viral things, but viral things aren't always evidence-based. Sometimes they are, but many times, obviously you're laughing, many times, I do think that as AI gets better and algorithms get better and we can study kind of medical education online in a little bit of a deeper form, I think we're going to be able to learn how do we boost evidence-based information to people that need it, and then help them, kind of tweak that into something that's applicable to them and something they can take into their healthcare provider. Or at least that's my, that's my hope. I'm fingers crossed.
Yeah, that's totally fair. And I would also say that that's probably not the only issue with the algorithm, but that is another chat for
another chat for another day, for another podcast that ain't this one. I am not willing to take that on.
I think there's just a wizard behind the curtain. It's like Plinko, like that one's viral, that one's going nowhere, that one's
and there's literally no rhyme or reason. No rhyme or reason. There's no, it's just pure madness.
Just some guy standing in a parking lot to a song. That's it.
Seriously.
1 million views. Here we go.
Seriously. Yeah, we're over here. Putting in hours of labor trying to get people, hours of labor, LOL, trying to get people educated on their birth, and 4 views.
Four views, 18 likes, 4 views, going nowhere. Yeah. Totally. But that guy in the parking lot, he's up to something good. Send that guy on a trip.
Shaking his rump.
Yeah, totally. Totally. Yeah, I hope that people don't take things at face value, because it can be, it's a wild west out there. You don't know what you're doing. It is.
Yeah, I often say that the internet is the wild west, and you have to be vigilant, you have to be smart, you have to kind of put boundaries into place and filter who you trust with your information, and then what you do with that information. It's not just enough to consume evidence-based information. You have to do something with that information to actually take control of your labor and try and have a good birth experience. So
absolutely. And I think we also have to remember too that algorithms and social media often play into biases quite a bit, right? So the more things that you think you believe in or want to believe in or are actively pursuing, it's just going to show you more of those accounts that support that viewpoint. So I don't really think it gives us at all a well-rounded information. It's not, it's not the encyclopedia. It's just sort of like you've taken 3 like pages from the encyclopedia and that's all you're reading. So I think people need to remember that as well, is that it's going to show you sort of what you want to see to support what you already think you know, as opposed to showing you things that make you think, oh, maybe I need to look into this a little bit further. So keep that in mind too.
Which with that, you could hack the algorithm. I mean, you could just flood your algorithm with evidence-based childbirth education, positive birth stories, home birth stories if you're a home birther,
positive
hospital
birth,
unmedicated hospital births, like positive epidural stories. You can hack the algorithm.
It's a good point.
Flood you with the stories that you want, but just be mindful of the things that you're consuming. And, we talk about this all the time too, but it plays into your mindset. If you're only watching the viral, really scary, traumatic stories, it's not going to be any wonder if you go into the hospital and have a scary, traumatic story. It's all your brain ever knew. So you need to be
that sells,
your
right?
brain. Oh my God, does it sell?
Oh yeah.
Of course it does.
Yeah, absolutely, right. And the things where you're being told tips to minimize your risk or things you can do to have a positive birth story, those aren't as sensationalized, right? So you're not going to see as many of those. So that's a good point that you can tweak your own algorithm, because wouldn't that be nice if you could be like, I don't want to see any horror stories, I only want to see beautiful positive birth experiences. Like, yes.
And instead the algorithm's like, we don't want you to see anything but negative, terrible things. Here's your news feed.
And men in gray sweatpants. Here you go. Perfect. Oh, love that for me.
Men chopping wood, and you're like, what the hell is this?
He chopping wood or skipping? Because then, yes, you're allowed in. That's fine.
I'm dead.
It's adding to a positive mindset.
This is positive. It is positive. This is great. Yeah.
Totally.
Oh my goodness. All right. We veered a little bit from postpartum hemorrhage.
We did.
I think we kind of covered everything. This feels good. I feel like if you've never heard of postpartum hemorrhage, or you've only heard about it in a very scary way, or you know about it because you know someone who has experienced it, that person likely didn't have this information. And I'm hoping that listeners, you guys are walking away with, yes, I hear you that it is a heavy and scary topic and we don't want it. But I hope that you're walking away with information that helps you understand what a postpartum hemorrhage is. What are some things that might increase your risk of having one? How can we mitigate those risks to hopefully decrease your risk of experiencing a hemorrhage? And then if you were to have a hemorrhage, what are the things that your medical providers are going to do to try and resolve that hemorrhage? Not that it makes it easier on you, but it just makes it a little less scary, so that because you know what they're doing, right? You know what the plan is in place if your body is struggling a little bit postpartum. So Tina,
information's power.
Absolutely. It always will be. Some providers saying like, don't ask questions. I don't want you to do this. You asking questions is actually the powerful thing to do.
Yes. And I want to leave people with this. It's actually a fairly common thing to happen. I just read a quote that says 14 million women a year worldwide experience postpartum hemorrhage. What I want you to know is that because it is a common thing, because it is an obstetrical emergency, the staff, at least at hospitals, and I'm sure midwives and obstetricians have this training as well, but personally speaking, staff in the hospital, we have a ton of training that goes into postpartum hemorrhage, a ton of knowledge about medications. And so because we have so experience with it, varying degrees of it, remember, postpartum hemorrhage does not mean that you are going to bleed and bleed and bleed and bleed. It can be a small postpartum hemorrhage that is manageable. So keep that in mind as well. But because we talk about it and we deal with it and we practice it, it becomes muscle memory. So I want to tell your listeners that your team of people that are taking care of you are very well versed in it. They are very quick to act, and they have a lot of people around them that are an incredible team that works all together. And so they are equipped to deal with it as an obstetrical emergency. And so I want you to have faith in the people that are taking care of you, that they are on the lookout for it. They are well trained on what to do if it does happen, and we're there for you.
That's awesome. I know that's so comforting to know. Again, taking a scary situation and making it comfortable, even though it's still scary. We're not taking the scary out of it. It's still going to be scary, but knowing that you're in good hands and you're in hands that are really well trained and hands that are just so, I think, acutely aware of everything that's happening, that you are going to be taken care of, it feels kind of like a warm hug.
Yeah, we want you to stop bleeding as much as you want you to stop bleeding.
Yeah.
So know that it's like it's our goal, like, yeah, to get you to stop bleeding. Like, no, we're like, yes, it's happening. We're gonna
All on the same page
we are
here.
stopping this immediately. We are all on the same page. Yeah, everyone in that room wants you to stop bleeding. I guarantee it. Yeah.
I love that. All right, Tina. So
Yeah.
if people
Yes.
wanted to connect with you, learn from you, work with
Yes.
you, where do they find you? How can they do that?
Oh my goodness, where am I not? I'm so obnoxious. Okay, so I am on YouTube. I have a lot of long form on YouTube. So if you're looking for things that are more complex and more involved and more complete, you can find me on YouTube. I'm Mama Nurse Tina there. No hyphens, no underscores, just straight up Mama Nurse Tina. And then otherwise, I'm on all of the other platforms, the Facebooks, the Instagrams, and the TikTok. And it's Mama Nurse Tina, 1M, MAMA, and underscores in between.
Nice. That is
Yeah,
perfect. This has truly been such a
lovely.
fun conversation, even on a topic
Yeah,
that is kind of heavy and scary.
yeah, it is a
I
little bit.
knew that when I had you on the podcast, I wanted to talk about postpartum hemorrhage because I
Hmm.
think you do a great job of presenting the topics that can kind of feels scary in a
Yeah.
way that doesn't feel scary. It feels empowering. It feels like, oh, okay, this is a risk. It can happen. And if it does happen, I know what to expect. I know what's going
Hmm.
to happen. I know what my staff is going to be doing. I know what the resolution is. And I think that exactly what you said, there's power in knowledge, even
Knowledge.
about the scary things.
Mm.
The one of the scariest things about pregnancy and birth is the unknown. And
A
so
hundred
the
percent.
way that we can get around the unknown is by knowing. And so thank you
Hmm.
for being here today, for helping us
Yes.
know about postpartum hemorrhage and
I help
understand
you.
what it might look like in birth.
I want you to know all the things. I would say knowledge and communication are like two things that can detrimentally affect how your birth goes and how your
Totally.
postpartum starts to roll. So ask those questions. And if you don't feel comfortable asking those questions for whatever reason, make sure you have somebody with you that
Yeah.
is comfortable asking those questions and
Yeah.
making those ripples. Yeah.
Yeah. And one of the things I always love to remind people, and you'll appreciate this too, is your nurse is your advocate. So if you're afraid
Hmm.
to ask something, you could always ask your nurse to ask for you or to ask your nurse to be in the room with you and help you
Yeah.
ask questions. Your
Yeah.
nurses, they want you to have a good birth. They want you
Hmm.
to ask your questions. They want you to feel empowered and feel in control of the things that are happening in your labor. So you can say, can you help me have this conversation with my doctor? Can
Yes.
you help me think about questions that I might not be thinking about? What would
Hmm.
you be asking if you were going to be making the decision to X, Y, and Z? What are some things that I should be thinking about? How does this impact, my labor that's to come or future labors, or will this impact things postpartum? Don't be afraid to have your conversations with your
Hmm.
nurses. I know we do a lot of talking about like ask your doctor, but your nurses are there too, you guys, and they can really be such a good sidekick for you that
Hmm.
can be a real game changer in your birth. And I think we forget that a lot.
We do forget that, and I think we also forget that that nurse can also make or break your experience.
Yeah.
So, if you have a nurse that you don't feel is necessarily your best advocate for your situation, you are always free to ask for a different nurse. And there are ways to do that that is not aggressive, that is not, judgmental at all. You can talk
Yep.
to the charge nurse, but I encourage people to make sure that it's a good match. And it may not be that's a bad nurse. It may just be that that nurse's vibe doesn't match up with your vibe and your expectation for your experience. But just remember that this is your one birth with this one baby.
Mm.
And I don't want anybody to ever look back and be like, I wish I had asked for a different nurse. Because always say, people remember your name if you're a phenomenal nurse in that experience, and people remember your name if you were a terrible nurse for them, right? So please don't feel like you have to have that nurse just because she was assigned to that 8-hour shift. It's your one birth with that one baby. So keep that in mind and do the things you can to make it a great birth.
I love that so much.
Yeah.
All right, you
Yeah.
guys. Thank you so much for being here with us
Thank you.
today. I know that you
Yeah.
guys have been asking to have Mama Tina on
Oh,
the
stop.
show.
Oh, stop. My head's not going to fit through the door. I have to turn sideways to get through buildings
Oh
here.
my goodness. Well, we will have to have you back. People
Yes.
really wanted to have you on the show, and I know that this
That's
was a big
amazing.
conversation for
Yeah.
everyone. Just top of mind. Again, when you get pregnant, there are certain things that come to mind, and I think postpartum
Hmm.
hemorrhage is one of those
Yeah.
taboo topics that we don't talk about enough, and we
Hmm.
only talk about it after you experience it.
Yeah.
And for me, that's just totally unacceptable. I want people to know about it before you go in. I want you
Yes.
to know risk factors. I want you to know how you can mitigate that and what's going to
Hmm.
happen if you do experience it. So, listeners, we will
Absolutely.
see you next episode. Until then, find both of us on Instagram. Tina gave you her Instagram. You can find me at Tranquility by HeHe or at the.birth.lounge. And until next time, toodaloo. Bye, you
Bye.
guys. Thanks for joining us. I'll see you next time on the Birth Lounge podcast. Until then, head over to Instagram and find us at Tranquility by HeHe and give us a follow. You can also check us out at thebirthlounge.com.